Fantastic. Can you see my slides, Cameron?
Yes.
Yes, okay,
Yep.
fantastic. Okay, lovely. Thank you very much. Thank you for your invitation to the MCN this evening. I'm Priya George. I'm a consultant diabetologist and I lead the antenatal diabetes service along with Dr. Rosalind Medena. Dr. Medena may come later on this evening, so she may be able to come through later, particularly if there are any burning issues from the obstetric point of view. So, the brief overview of what I'm going to talk about today is we'll start off just a brief introduction into gestational diabetes, and I'll speak a little bit about our new screening pathways. The antenatal pathway for those who have been diagnosed with gestational diabetes. We have, over the last year, introduced a new online platform called GDM Health. So I'll just let you know about that. It allows us to do some remote monitoring for patients with gestational diabetes and also just share with you the new postnatal pathways that I believe have been approved by the GP subcommittee. So I'll share with you those pathways just to remind you of what that involves. We'll then go on to talk about women with pre-existing type 1 and type 2 diabetes who become pregnant. So again, I'll talk through the antenatal pathway and the postnatal follow-up. And then I'd like to just conclude by sharing with you about the importance of pre-pregnancy counselling. We've got Ella Hopley, who's a fourth-year medical student who has done an audit with me last year, and she's going to share some of her findings from the pre-pregnancy counselling audit. So that's
Priya,
the brief.
Priya,
Yep.
can I
Sorry
just...
to interrupt you. Yeah, or Cameron, on you go.
Yeah, Priya, your slides haven't moved on. It might be better if you changed it into slideshow mode.
It's on slideshow, I think. Oh, okay.
All we can see is the screen, like your computer screen, and the first slide. Now you've clicked on the second slide.
Is that coming up as a slideshow or?
No.
No, okay. What about now?
That's a slideshow now,
Mm-hmm.
and that's the outline that you've just explored with us. So that's good.
Okay. What about if I were to move on to the next one? Can you see that?
That's going on to the next one. Fine. Gestational diabetes.
Yes. Okay, perfect.
Thank you.
Okay, great. Thank you, Cameron. So gestational diabetes. So rough incidence is about 5 out of 100 pregnancies here in the UK. Gestational diabetes is defined as hyperglycemia in pregnancy that is below the diagnostic thresholds for frank diabetes. And it occurs as a result of the placenta, particularly producing some hormones such as estrogen, progesterone, human placental lactogen. All these hormones are anti-insulin hormones and they cause a relative insulin resistance. And it prevents the body using insulin as it should. So the insulin production is just not able to meet up with the rising insulin resistance. And as a result of that, blood sugars increase. So in terms of screening, the SIGN guidance suggests that we should screen at-risk patients at booking with an HbA1c. Now, this is not something we've been doing over the last few years, but we are now introducing it into our more recent guidance that there will be a booking HbA1c done by the midwife who does the booking appointment. And that's really to find out if this woman has pre-existing diabetes going into the pregnancy. There'll be further screening between 24 to 28 weeks of gestation with an OGTT. And locally, where we use the SIGN guidelines in terms of the diagnostic criteria for the OGTT, that's a fasting of greater than 5.1 or equal, or a 2-hour glucose of greater or equal to 8.5. So why is it important to diagnose gestational diabetes? We know from various studies over the years that there is about a 1.75-fold increase in the risk of macrosomia, and that results in an increased risk of a complicated birth. We also know that it increases the risk of neonatal hypoglycemia, and that increase is incremental with a degree of maternal hyperglycemia, especially during labor. There have been several case control comparisons, and one reported a few years ago suggested that neonatal hypoglycemia is up to 5% in neonates delivered to mothers with GDM compared to less than 1% of controls. We also know that maternal hypertension frequently complicates GDM, and so it's very important that we routinely assess both blood pressure as well as urinary protein. Preeclampsia is also increased in GDM, and the risk is again related to increasing maternal glucose levels. So for all these reasons, it is important to have good blood glucose control throughout pregnancy. And as a result of that, we can not only reduce the risks of the above, but also reduce the risk of trauma during birth, reduce risk of induction of labors, C-sections, and perinatal death. Okay, so this is our new diabetes screening pathway. And if I can focus in, are you able to see the slide well, Cameron or Elaine?
I can see it.
But it's a little bit blurred. Now, if I do this, does that?
That's much better.
Okay, fine, good. So, so just to highlight a couple of points. So these are our women at risk. So anybody at booking who has a BMI of over 30, they have had a previous stillbirth after 22 weeks, or they've had a previous macrosomic baby, that's the baby weighing over 4.5 kilograms, or indeed if they've had previous gestational diabetes with a previous pregnancy, a history of polycystic ovarian syndrome, a family history of diabetes in first-degree relatives, or a family origin with a high prevalence of diabetes, such as in South Asians, Black Caribbeans, or Middle Easterns, then we would offer them an HbA1c at booking. Now, following that, if the HbA1c at booking shows that their HbA1c is, sorry, I've gone to the wrong one. Oops. If their HbA1c is above 48 at booking, then we know this is likely pre-existing diabetes. So the woman is coming into the pregnancy already with diabetes. So they would have an immediate referral for blood glucose monitoring, and we would see them in the diabetes antenatal clinic within 1 week. If they have an HbA1c in the indeterminate level, 42 to 47, again at booking, we would again follow a similar pathway, and we would want to see them quite quickly in our diabetes antenatal clinic and monitor them quite closely over their pregnancy. If their HbA1c is less than 42, then we would then go down, if they've had previous GDM, then we would refer them for an OGTT as soon as possible. If that shows an abnormal result, then, oh, sorry, this is just, sorry. If that shows an abnormal result, then again, we would say this lady is likely to have gestational diabetes. If it shows a normal result, then they are booked in for an OGTT at between 24 and 28 weeks. Okay, so that's that pathway for those with any risk factors. Now, if they have none of the risk factors at booking, then there's usual care. So they would go through usual either community midwife care or obstetric care, depending on whether they have any other risk factors for secondary care. If at any point during the pregnancy, a pregnant woman were to develop either polyhydramnios or a large for gestational age baby, or glycosuria, as it's shown here, then we would immediately go and arrange an OGTT. And once again, if it's a normal result, no action. If it's an abnormal result, gestational diabetes. And then they would be seen for blood glucose monitoring and arranged to be seen at our clinic. So that's the screening pathway that we have at the moment. So midwifery check at booking, and dependent on the risk factor profile, they would go down these two different pathways. Okay. So what happens if they have a positive diagnosis of gestational diabetes? So the first thing is they are registered with GDM Health platform, which I'll talk to you about in a moment, via an app. And they're then referred to the Friday clinic in our Nine Wells clinic, run by our healthcare assistants, where they would be taught how to do blood glucose monitoring. We'd be giving them a patient information leaflet, which we have in multiple languages. And there is an immediate communication to the GP regarding issuing test strips and lancets for blood glucose monitoring. We are at the moment developing a GDM education video to be played at that Friday clinic as well, just to give the women a little bit more information in the very early stages. They're then referred a few days later to our Tuesday afternoon clinic. This is a clinic primarily run by the obstetrician and a dietitian. And at that point, there is a one-to-one discussion regarding their diagnosis. They have a full dietary assessment. And by that time, we have about 5 or 6 days worth of glucose data. So we can have an immediate look at what's happening to the blood glucose and whether we feel that further dietary modifications are what's needed, or whether we feel that we need to jump in there with some medications. One thing we are developing at the moment is at that clinic appointment, there will be a letter generated via Badgernet, and that will be issued to the GP practices asking for coding for gestational diabetes to be done via the practices. And that will enable, I suppose, a proper coding in the GP practice. It'll enable good audit purpose for us. Audit purposes will be useful. And it may also prove useful for yourself in terms of recall and retesting, annual retesting thereafter. So a quick word about GDM Health. So we introduced this remote online platform back in February 2022. It's an online remote glucose monitoring platform that was developed by the team in Oxford. And so what it enables us to do really is that women do their blood glucose testing on a Bluetooth enabled meter. So as soon as they do their blood glucose testing, that blood glucose immediately goes up into the web. There's also functionality for them to write down their food intake and what they're having, any notes, and immediately that we are able to review that as and when we need to. The women are encouraged to enter blood glucose readings 4 times a day. That's fasting, which our targets would be less than 5.5, and a 2-hour target of less than 7 after main meals. As I said, all these results are then uploaded onto our healthcare online platform. And very smartly done in GDM Health is that all our women are on one platform, and they are then triaged according to their blood glucose data. So we see immediately, based on red flags, women who have blood glucoses out of in the target range. So once a week, either myself or Dr. Sit, who is the other diabetologist who runs the clinic, we have a look at GDM Health, and we can immediately tell within a few minutes how many of our women within the practice, within our clinic, who have gestational diabetes are outwith of targets, and we can then focus our efforts on these ladies. We would then allocate the most appropriate MDT professional, whether that is a dietitian if we feel that they need more dietary modifications, or it's a diabetes specialist nurse if they're already on insulin and actually it's more insulin modifications that they need or titration, or whether we need to see them on a face-to-face appointment if there's any other issues. So that's been a really great platform for us in terms of organizing our workload and being able to use the expertise of all the different MDT members in our team. So of course, our main goals for GDM is that we want to strive for good glycemic control throughout pregnancy in order to reduce those complications that I talked to you about earlier. So I suppose the mainstay of treatment is education. So there is a lot of time spent in that afternoon clinic regarding lifestyle modifications. So as I said, there is a one-to-one with the dietitian where the diet sheets are looked at and modifications are recommended, snack lists are recommended. Activity is, we encourage the women to maintain good activity and 30 minutes of gentle to moderate exercise every day, and of course, good blood glucose control. If that is not adequate, then we recommend metformin, and we've been using metformin, or metformin has been used since the 60s for treatment of gestational diabetes. However, it has never had a license for use in pregnancy until beginning of last year. And this was following the CLUE study, which reported on, it was a large review of data from a non-interventional cohort study of population registries in Finland. And it showed safety of metformin use in those who are pregnant. The only thing which we have had slight signals about is that metformin exposure compared with insulin exposure during pregnancy has been associated with increased relative risk of being small for gestational age. So if there is any sign of growth retardation or deceleration on the antenatal scans, then there may be some discussion along with the obstetrician as to whether we should continue with metformin or not at that point. If metformin, once we reach the maximal tolerated dose with metformin, then the next option would be going down to insulin therapies. So that is what we have in terms of what we can use to treat gestational diabetes. All our other oral anti-hypoglycemic drugs do not have a license for pregnancy, so we don't use any of them. Okay. So we conducted a small audit. Of course, our audit tool, GDM Health in itself, has an integral audit tool. So at any point in time, we can actually review our data quite quickly. And what we found just looking at the dynamics of the clinic is that since starting the trial in February 2022, we've had a significant reduction in unnecessary face-to-face and telephone contact for blood glucose monitoring. We've also been able to go paperless. So all our records are now done via GDM Health. As I said, it's a very powerful audit tool. Pre-GDM Health, so that is pre-2022, women would be reviewed in the gestational clinic either face-to-face or via telephone 6 or 7 times following the diagnosis of GDM. So that would be 1 to 2 weekly. And each of those consultations would require the team going through with the lady who would often possibly bring or not bring their paper blood glucose diary with very sporadic blood glucose results. We wouldn't be able to tell whether it was before or after food. Often there'd be no record of their food intake on the diaries. So it'd be very difficult to interpret that data. And And it would often take, and this again, we did an audit of this would often take up to 10 minutes to try and extract that data, either face-to-face or via the telephone. Post-GDM, women are now reviewed twice. That's a diagnosis, so that'll be either that's if it is between 24 to 28 weeks, and then at 36 weeks. So we wouldn't offer them routine appointments in the clinic. However, we would assure them that we are checking their blood sugars every week. Of course, the women have access to us at any point if their blood sugars are going off target. So they all have access to our DSNs, dietitians. They know that we are checking their blood sugars every Tuesday, and we'll be in contact with them if blood sugars are veering out of target. So as a result of this, we've been significantly able to reduce the number of unnecessary interactions. There's, again, a significant reduction in delay to intervention. So we're able to act promptly and timely in order to start medications if needed. Because 90% of our women now on GDM Health are recording their diet with every single meal, we are now able to also find that we're reducing unnecessarily pharmacological intervention. Because if there is a clear-cut reason why their blood sugars are high because of their dietary intake, then we can focus on the diet. And some women will adhere to that, and as a result of that, they're not needing pharmacological therapies. So as I said, antenatal face-to-face is now routinely only twice after diagnosis, compared to the 1 to 2 weekly prior to GDM Health introduction. However, the women do have community midwife follow-up every 2 weeks. And this is in line with the Best Start initiative, trying to improve both neonatal and maternal outcomes. And the Best Start initiative really is to try and improve continuity of care for women with gestational diabetes. So all women have a named community midwife that they see every 2 weeks. And then they only come to the hospital really at those 2 crucial visits, and intermittent and in between if there is a need for pharmacological or a need for insulin to be started. So going on now to the postnatal pathway. Again, so if I can run, this is no longer draft. I think this has now been approved by the GP subcommittee. So these are for women with straightforward GDM diagnosis. So they are diagnosed, they're managed according to our guidelines. We will, as I said, and this is being worked on, we will communicate that diagnosis to the GP practices via BadgerNet template letter, and we will ask for the practices to code the women so that it shows that they have gestational diabetes, and this will auto feed into our Sky Diabetes system as well. So again, it'll improve our audit data and potentially improve recall as well. So they're then referred to Joint Diabetic Clinic, managed, as I said, and then delivered. Following delivery, now this is something new as well, because following delivery, we used to write a letter to GP practices, to individual GPs saying, you know, this lady has had gestational diabetes, can you please offer them a fasting glucose 6 to 12 weeks? Over the last 2 years, we are now writing letters directly to the patient, reminding them of some of the sort of key messages that we focused on during their antenatal care, which I'll talk to you about in a minute. But that letter is going directly to the patient with a copy to the GP. It's reminding them that they need to seek out that 12-week post-delivery stage 2 fasting glucose plus or minus the HbA1c, the diagnosing diabetes test. So if that is positive, HbA1c of greater than 48, then they should be directed to the type 2 diabetes pathway and referred on to the Aviva diabetes support. If it is 42 to 47 or less than 42, then they should be offered annual screening thereafter. The other new thing that we have introduced is that all women with previous gestational diabetes are now able to self-refer to the Aviva Diabetes Prevent program, which again I'll talk to you about in a moment. But that's been really helpful in terms of, we have a lot of contact with them during the antenatal phase. So it's quite nice to be able to refer them to a program to try and reduce those risks of type 2 diabetes. So that's for the straightforward GDM diagnosis, ladies. Now, if the second pathway we have is for those ladies where the OGTT is slightly suspicious. So either now we've defined that for the moment as a fasting of greater than 7 or a 2-hour glucose greater than 10 anytime during the antenatal OGTTs. So if that were to happen, they of course get our regular antenatal diabetes care. But we find those women often require pharmacological intervention much earlier, and then they're delivered. Immediately following delivery, if their fasting glucose is greater than 7 or indeed in the double figures, then the inpatient diabetes team will be contacted just to review what is that diagnosis. Is it still gestational diabetes? Unlikely, or actually have we just been dealing with type 2 diabetes all along? However, if the fasting glucose settles down as it does in most cases, then the patient is discharged. The letter then is sent once again to the patient with a copy to the GP. However, this letter is slightly different. Patients have already been advised during the antenatal care that their OGTTs are on the higher side. They will then be advised to continue blood glucose monitoring, not at the same frequency as during the antenatal care, but intermittently, either fasting or 2 hours after meals, once, twice a week, but particularly if they are feeling unwell. If their blood glucose goes into the double figures at any point, then they are advised to contact my secretary and I'll organize a soon review with them. If blood sugars are single figures, then they have been advised to go for a 6-week post-delivery fasting glucose test. Now, this is replacing the previous OGTTs that we used to offer in the postnatal period in this category of women. So OGTTs postnatally have now stopped. And instead of that, this is what we are trialing out at the moment. And they are then offered a 6-week fasting blood glucose test with an HbA1c if needed. Following this, myself, we are keeping a database of all these women. So we know when they should have got their six-week blood test, and we'll review that blood test if it's been done. If it's not been done, we'll remind the person to go and get that blood test, and then following that, we'll write to the patient and advise them for a further. If it's normal, we'll advise them for a further blood test at 12 weeks. If it's abnormal, of course, we will redirect the patient. It may be that they've now actually developed type 2 diabetes, so we'll redirect, let them know of their diagnosis, and copy the letters to the GP practices. So if it is indeed at either 6 or 12 weeks a high HbA1c, then they go down the type 2 diabetes pathway, and Aviva diabetes should be offered to them. If it is less than 48, then they should be offered annual screening once again, and again reminded that they have the option of self-referring to the Aviva Diabetes Prevent program. So Aviva Diabetes Prevent has been offered to our ladies with gestational diabetes now for over a year. So all women, as I mentioned, following delivery are sent a letter reminding them of some important points. So number one, they are reminded that there is an increased risk of type 2 diabetes. 1 in 2 ladies will go on to develop type 2 diabetes in their lifetime, so quite a significant risk. They're reminded that they need to get their blood sugar levels checked, fasting blood sugar levels checked at least once a year. And they're also given a QR code to enable self-registration to the Aviva Prevent platform. So, so I'm told from the Aviva Diabetes Prevent platform basically matches a woman with a personal health coach and a dietitian. And it's a 9-month program available for all women who have that previous diagnosis of GDM. So I'm told by the prevention framework that briefly of the audit they've done so far, people on average are losing about 4.5 kilograms on that 9-month program. So quite a significant reduction. So we will hopefully get some longer term data from them over the next year to 2 years. So that's brief overview of gestational diabetes. Can I stop now and just see if there are any immediate questions before I go on to the next bit, or would you like me to do it all at the end? What do you think, Cameron?
If anybody's got any particular questions about this section, then please either raise your hand and speak or type something in the chat. Thank you, Priya. That was really informative. It's really complex, but it's really simple, if you know what I mean.
I'm glad I made it look simple.
You know,
Yes.
the two numbers that stand out overwhelmingly to me are, first of all, 1 in 20 pregnancies, 5 out of 100 in Tayside, and then the very stark number that I've always been startled by is 50%. 1 in 2 people with gestational diabetes will become diabetic. So opportunistically, to me, the way I think these are absolute cherries to pick going forward. If we could prevent one person becoming a type 2 diabetic and changing their life in a positive way, then that's enough for me to retire with. Does anybody have any particular questions about those pathways, about the gestational diabetes pathways? I'm not seeing any hands and I'm not seeing any chat. So if not, thank you, Priya. Move on to pregnancies in people with already known to have diabetes.
Okay, great. Okay, so so this was a study. This was actually an exploration of all pregnancies in Scotland that were complicated by diabetes. It was published back in 2018, and it looked at Scottish diabetes pregnancies over the last 15 years. So some revealing stuff came out of that. Number one, the pregnancies complicated by type 1 has increased in that time span, and it is currently 1 in 210 of all pregnancies are complicated by type 1 diabetes. And 1 in 504 pregnancies are complicated by type 2 diabetes. Delivery was occurring 2.6 weeks earlier in patients with type 1 and 2 weeks earlier in patients with type 2. Over that 15-year period, it was found that both elective and emergency C-section rates had increased. So pregnancies in these patients remain high risk. So there's further studies and collaborations looking to see how we can understand the causation of this and what are the most effective interventions to try and start to reduce these adverse outcomes. So some of the focus points from that paper suggested that we should look at improving our pre-pregnancy care. We should look at improving efforts to improve glycemic control and best obstetric practice to try and reduce risk. So pre-pregnancy HbA1c, this is something that's really been targeted over the last few years. And there was a recent study just done last year. This was a retrospective study, one of the largest of its kind, of pregnancies in 678 type 1 diabetes patients at Lille Hospital, and it was done between 1997 and 2019, so spanning quite a big time span. So what they found is that higher HbA1c over 6.5% in the first trimester was associated with composite criterion. So that is either one of prematurity, preeclampsia, or a large for gestational age, or C-section. And the odds ratio was 1.04, so 4% increase if the HbA1c was greater than 6.5%. Now, interestingly, even if the HbA1c is optimized by the third trimester, the risk of that LGA baby still persists. So that suggests to us that actually it's the going in HbA1c which is the most important. So that is why pre-pregnancy counseling is really important. Other factors that could contribute to this are increasing BMI in patients with type 1, immune mechanisms, and also glycemic variability. So some of the key points in pre-pregnancy is we need early referral to pre-pregnancy clinics, either both for type 1 and type 2 diabetes. I think pre-pregnancy counseling is not just something that should be just in secondary care, but I think any healthcare professional who is speaking to a lady of childbearing age who is not on contraception should start having those discussions about pregnancy and pre-pregnancy counseling. The target HbA1c prior to conception should be less than 52. That's our SIGN guidelines. It's a bit tighter. NICE suggests less than 48. And if the HbA1c is greater than 86, then they should be actively advised to avoid pregnancy because of the very high risk of miscarriages and congenital malformations. So all these patients who are childbearing, sexually active, who are not on contraception, they should have their medications reviewed for teratogenicity. I use the BUMPS website, which is quite useful if you want to look up medications to see whether they're safe in pregnancy. Make sure that they're on 5 milligrams of folic acid. Ideally, they should be on this for at least 3 months prior to conception. Ensure their screening is up to date. That's mostly the eyes and the kidneys. Make sure their blood pressure is well controlled. Aim for a healthy weight, BMI of less than 25. Talk about smoking, offer smoking cessation programs if necessary, and think about, if they are in the high BMI range, think about exercise programs, and if they satisfy the criteria, discuss with them whether they would like to be referred to the weight management program. So now briefly, just on our pathway for pre-existing type 1, type 2 diabetes, the pregnancy patients should be advised to register via BadgerNet. As soon as that referral comes through BadgerNet, we have 2 new midwives that are purely there for patients with type 1 and type 2 diabetes. So they will pick the women up and they will book them into the next face-to-face antenatal diabetes clinic. So hopefully there shouldn't be too much of a delay. So these are some of the big points, I suppose, through pregnancy. So as I mentioned before, folic acid at least 3 months before conception, and we would advise that to be continued up to 12 to 15 weeks of gestation. Following that, they should be on aspirin, 150 milligrams, and that is to reduce the risk of preeclampsia until delivery. There was a big study done 2 years ago called the CONCEPT study, and that looked at continuous glucose monitoring in patients with type 1 diabetes in pregnancy. And the study was very, very revealing, such that it has actually changed national practice and has now been included in all the diabetes in pregnancy guidelines. And what it showed is that women who were on real-time continuous glucose monitoring, they had a much reduced, they had improved neonatal outcomes. So that was either a lower incidence of LGA babies, neonatal hypoglycemia, and less admissions into neonatal intensive care unit. So for all those reasons, we have Scottish funding to be able to offer all these women real-time CGM for a 12-month period. The target range in pregnancy is very tight. It's 3.5 to 7.8 compared to the 3.9 to 10 out with a pregnancy. So when they're on these continuous glucose monitoring, we're looking for a time in range that is the time in range of greater than 70% of their readings to be within that target range. In order to help women to achieve those target ranges, of course, the real-time CGM will help. If they're on pump therapy, we'll support them with that. And now we've seen a few women now who have been on the hybrid closed loop, who have come into pregnancy, and we've been able to support them with the hybrid closed loop throughout their pregnancy. And of course, they're achieving fantastic results on the hybrid closed loop via pregnancy, but it's requiring quite a bit of MDT intervention as well, as their requirements are changing quite rapidly through pregnancy. These women, as I mentioned, are high risk, so they do get very close monitoring from our team every 1 to 2 weeks, depending on how well they're achieving their glycemic targets. So, and in the postnatal period, ward team would contact the inpatient team if there were any immediate concerns with glucose control. Women are advised then to return back to their pre-pregnancy insulin doses almost immediately postpartum. They're then booked into my clinic in 6 to 8 weeks postpartum. And of course, they have access to our DSNs if there are any problems sooner than that. And then we would advise them to get an HbA1c check at 3 months postpartum. After I see them once, either myself or Dr. Sitt, we will return them back to their original secondary care consultant, or we will return them back to primary care if they're not on any injectables. So I'll maybe hand over to Ella Hopley, who's done a pre-pregnancy audit with us. So over to you, Ella.
Hi there, is my mic okay?
Yes, we can hear you fine.
Perfect.
Yeah.
So hi, my name's Ella. I'm a 4th year medical student currently, but back in January and February time when I was in 3rd year, I spent a month with Dr. George shadowing her and also completing this audit, which as on topic is focusing on pre-pregnancy counselling on those with pre-existing diabetes in Tayside. Next slide, please. So what we hope to do with this audit was to establish the prevalence of pre-pregnancy advice being given to women with type 1 and type 2 diabetes within Tayside. The benefits of pre-pregnancy advice has already been established for a long time now, and Dr. George touched on that earlier this evening as well. And so what we hope to do with this audit was to look at the patients that fit our criteria, which I'll go over in a second, to look at who had been receiving pre-pregnancy advice prior to their conception. So what we're primarily looking at was the documentation of any attendance at pre-pregnancy clinics or the mentioning of any pre-pregnancy advice, as Dr. George mentioned earlier, at any other appointments that had been documented already. So the information that we specifically took into account was their HbA1c prior to conception, whether they were presenting on folic acid for 3 months, and also the documentation of letters that we could also find that had been sent to secondary care. Next slide, please. So the standards I used within this audit were the NICE guidelines and the SIGN guidelines, which have already been touched on this evening. And so the main aim of the advice is to empower women to have the best pregnancies they can, as all women with diabetes pre-existing are able to have normal pregnancies just like other women, as long as the extra precautions are taken to reduce the risk of complications throughout their pregnancy and after. The standards emphasise the importance for planning for pregnancy and ensuring that these women receive education from adolescence to adulthood about what would be involved in pregnancy for them. It's also important to mention that this isn't just something that concerns GPs, it's something that all healthcare professionals that come in contact with women with type 1 or type 2 diabetes should be ensuring is being mentioned, and ensuring that they have the most amount of information possible to have as safe a pregnancy as possible. Next slide, please. So the way that we went around doing this audit was by looking between the period of January the 1st of 2022 to December 31st of 2022 of all the women with pre-existing type 1 or type 2 diabetes that gave birth in 9 Mills and Perth Royal Infirmary. And so there was 32 women that met the criteria for this audit, and these women were identified by Dr. George through patient lists, and we also used a clinical portal to look through outpatient letters, booking scan documents, and postnatal summary letters as well to collate our information. Next slide, please. So there's quite a lot going on the slide, so I'm hopefully trying to take you through it and try and simplify it as much as possible. So I'll first go through the women with type 1 diabetes. So for our audit, there were 17 women that had type 1 diabetes, and within this there was 19 pregnancies. And so as you can see by the first row here, that the attendance at pre-pregnancy clinics, 14 of those women were never referred to a clinic, with only 2 having attended and 3 women in the referral process for that. Furthermore, the advice being given was only noted to have been given to 7 women, and 10 women were not given any advice. Only 4 women were on folic acid for 3 months prior to their conception, and 12 women therefore were not at all. The HbA1c pre-pregnancy, as already mentioned, the aim from the slide guidelines is to be less than 52 millimoles per mole, and this was averaging at 70 millimoles per mole, which is too high. Or is higher than what should be being recommended for conception. While also looking at their medication list as well, sorry, I should have mentioned that earlier, this was something we also looked at. There were only 3 women on teratogenic medications, which were all stopped within the first trimester after finding out they'd become pregnant. And so moving on to the type 2, the women with type 2 diabetes, there were 15 women and 15 pregnancies. And so from these women, only 2 women attended a pre-pregnancy clinic, and 1 woman was in the referral process when she found out she was pregnant, which leaves 12 women who had never been referred. Again, to re-emphasise that, pre-pregnancy advice had only been given to 4 women, so again, the overwhelming majority of 11 women had not received any advice. Folic acid had been prescribed for 3 months prior to conception to only 2 women, with a further 2 women having been on it for 1 month and then became pregnant, and there was 11 women without any folic acid prescribed when they reached secondary care. Again, looking at the HbA1c's preconception, this was higher than what is suggested for conception for women with pre-existing diabetes, and the teratogenic medication noted on the women's medication lists, only 3 were on teratogenic medication, which again, I believe, if I remember rightly, 2 of them were stopped within the first trimester and 1 of them continued the medication upon their doctor's advice. Next slide, please. So to try and summarise that further, so it's a bit more simpler to understand, out of the 32 women that met the criteria for our audit, only 11 women had received some form of pre-pregnancy advice. So as I mentioned earlier, this is including attendance at pre-pregnancy clinics or any documentation of any advice being given. And furthermore, of these 11 women, only 6 of these women were found to have been on folic acid for the 3 months prior to their conception, which is almost half of the women that are receiving advice. And so I looked into this further, and I've listed the reasons as to why what happened to those other 5 women, essentially. And so 2 of them had been on folic acid for a month and then had become pregnant. 1 woman had been advised to lower her HbA1c before conception, but hadn't started folic acid while she was doing this and had ultimately become pregnant. 1 woman was using contraception and became pregnant, and another woman did not follow advice following recommendation. Next slide, please. So hopefully from today, it's been a refresher in women with pre-existing diabetes and the pre-pregnancy advice that should be being given and what sort of things to look out for. And hopefully it's also raised awareness for Dr. George's pre-pregnancy clinics that run in 9 miles as well, for that as a referral pathway. Personally, I also hope that from this audit that we did, that to create a poster that would hopefully be put up in both primary and secondary care waiting rooms or any sort of area which could be useful for patients to see to get further advice. Next slide, please. And so just to conclude, I thought just to include a slide on some simple questions that can be asked in consultations with women with pre-existing diabetes that are of childbearing age. So the first question being quite obvious of, are you planning to be pregnant? And if yes, thinking about, are they on any folic acid already? What is their HbA1c at that point in time? Are they up to date with all their screening appointments, so their eyes and their kidneys? And looking at lifestyle modifications as well, if this would be necessary for that woman. And if not, ensuring that they're on a form of contraception to protect them from pregnancy and to let them know to get back in touch if they do think of this as something that they want to do in the future. And again, also making sure that they're not on any medications that could cause any issues if they were to suddenly become pregnant. Next slide, please. So yeah, here are the standards that I used within the audit that I wrote, and yeah, that's the end of the presentation. So thank you so much all for your time, and thank you again to Dr. Priya George for letting me help her on this audit and for giving up so much time and helping me prepare for this. So thank you.
Great, thank you so much, Ella. Okay, so just to conclude and to summarize, so hopefully the last little while has given you an overview of what our gestational diabetes pathway looks like, including the screening pathways and particularly the postnatal new pathways. And hopefully now also with Ella's audit, just to reiterate the importance of good pre-pregnancy counselling. As Ella mentioned, it's everyone's responsibility, not just pre-pregnancy clinics, but any healthcare professional who's coming into contact with the patient should start having those conversations with them. And by all means, please do refer to my pre-pregnancy clinic if the patient is agreeable, particularly if their HbA1c is above target, and I'll aim to see them quickly. I also have good access and links to the assisted conception unit. So if nothing is happening despite good blood glucose control, then I can also, and the patient is wanting a referral to assisted conception, then I can also discuss that with them. And also hopefully you've understood a little bit about our pre-existing type 1, type 2 diabetes pathways as well. Okay, so with that, I will finish, but I don't know how we're doing for time. How are we doing for time?
We've got a little bit of time, so thank you very much, Priya, for pulling all that together and demystifying what is there and really highlighting that everybody has a role in this, which is great. Thank you also to Ella for presenting your audit, which was also really informative. We've got one question. If people have got questions, as I said, just type them into the chat or raise your hand. One question, if somebody's allergic or contraindications to non-steroidals, to aspirin, do you automatically just recommend fragment injections?
I would have to pass on that, actually. I would probably, they would probably have a score done by the obstetricians. Ah, there's Roz. Roz is here.
I see Roz's hand going up.
You're fantastic, Roz.
Hi, sorry I was a bit late. No, so aspirin is not used for thromboprophylaxis. It's a drug used for preventing preeclampsia. So I know we recommend 150 milligrams. So if the patient has a contraindication, we don't give them fragment. We just give them home blood pressure monitoring. This is what we would be doing. But we can't really prevent preeclampsia if there's no if there's a contraindication to aspirin. A fragment is not the alternative. Fragment is only for thromboembolism and not for preeclampsia prevention. Thanks.
So thanks, Ros. So yeah, once again clarifying the reason that we give a drug rather than us jumping to conclusions. So thank you. That's really helpful. Any other questions from anybody else? Ros.
Sorry, thank you, Priya and Ella, for a wonderful presentation. I just had a question. I think I'm also questioning about basically the pre-pregnancy counseling. I would be interested to know whether there were any Paris women in the cohort for the audit, because my hope is that when we see these women already with pre-existing diabetes, a lot of them go through the service many times. And if we're not getting the message right for them to actually think, before I become pregnant again, I am accessing care and actively, seeking for folic acid, seeking pre-pregnancy assessment, then maybe we're not getting the messages through in the antenatal service. So this is something I'd like to know, because I think we need to give women ownership of their own health and to encourage them not to be passive when it comes to pregnancy and lifestyle in general. So I would be interested to know if these are women who've already been through pregnancies, because they should really not be becoming pregnant again without having had relevant care. Of course, most pregnancies are unplanned, we know that, but it will be interesting just to know whether there were any Paris women who are just not accessing. And the other question for GPs I have is, when it comes to accessing folic acid, how do women access folic acid quickly? Because that's always something we struggle to know. Thank you.
I don't know if Ella, if you can answer that question about the Paris women.
From what I remember from looking at the data, it wasn't something that we noted down when we were collecting the data. However, I do remember there's at least one case of a woman that had developed gestational diabetes in a previous pregnancy and then had gone on to develop type 2, I believe, in between that. And then I don't think she'd received any advice in between that time for her then following pregnancy, because if it was quite a quick time between diagnosis and her next pregnancy. But off the top of my head, I'm sorry, I can't remember any other Paris women besides potentially that one case.
I think looking through the data, it's not just, I think there are women who are looked after in secondary care who have had previous pregnancies, and potentially those discussions have not happened in secondary care also. So I think we need to raise awareness amongst our own secondary care colleagues as well about having those pre-pregnancy discussions, not just in a pre-pregnancy clinic, but outwith of that in all general diabetes clinics. So I think there's work for us to do as well. Yeah, and then there's of course women who are having big inter-pregnancy intervals, so they're forgetting about potentially the things that they need to look out for and being on folic acid prior to that. But I think probably that's something that we could have discussions with at annual screening visits, either with secondary care or primary care. We're screening for eyes and kidneys and urine. Try and make it a practice also to ask about pre-pregnancy planning as an additional question. So I think maybe that's maybe about changing the culture of how we do our consultations as well.
Yeah, and just as an aside, in primary care, there's obviously some really useful resources. Diabetes UK has a useful summary page of planning pregnancy in people with diabetes. And as Andrew has questioned My Diabetes My Way, which of course we should encourage every person with diabetes to engage with and have a look at, have a couple of modules. They've got a planning pregnancy module and a diabetes in pregnancy module that people can look at with some really useful evidence-based information there. Ros, your question about the folic acid, as far as I'm aware, is freely available for people. They can get it through their pharmacy. But as Claire is typing at the moment, most people access folic acid after they found out they're pregnant. But yeah, there's a role there for the community pharmacists, and obviously it can be done on prescription in a relatively swift way if needed. Was there anybody else? Any questions? So the main information that I'm taking away is as usual, it's having conversations about things, being more aware of things, and that's not just us as healthcare professionals. It's having those conversations with people. That leads to empowerment, and empowerment, whether it's somebody who is diabetic or not, if they're planning on becoming pregnant, then having some conversation about planning pregnancy. It might not be with a healthcare professional, it might be with online resources, it might be with their families, all sorts of things, but empowerment will lead to better outcomes. I firmly believe that. So, but the more conversations we have, the more that we feel that it's everybody's responsibility to try and do a bit, then the less likelihood there are to be problems going forward. So thank you once again. Thank you, Priya, for your time and demystifying the complex. Thank you, Ella, for your work, and thank you also to Ros for your input as well. If anybody has got any other questions, please get back to me or Elaine at the MCN, or particular questions, then Priya or Ros are your people from an obstetric and a diabetic point of view. And we love being contacted for requests for information. It is I speak personally, it's a nice part of my role. So the next quarterly MCN online forum is planned for December. I think we picked nominally a date at the beginning of December before things started to get a bit tricky in December. So we picked nominally Wednesday, the 6th of December. We don't have a topic for that online forum. If anybody has any topics that they would like us to explore with a speaker, then please contact me directly. We're totally open to suggestions. Otherwise, we'll get a topic that comes into my sphere of knowledge in the next few weeks. So look forward to seeing everybody on the 6th of December, when it will be even darker and even colder, but things move in a seasonal way, as we said. So thank you, everybody. Enjoy the rest of your evening, and thanks once again to Priya for all the hard work that you've put into tonight.
Great. Thank you so much, Cameron. I just leave you all with a couple of questions that you can maybe think about in your own practice. And if you have any suggestions on how we can improve all these things, I'd be very keen to hear about how we can improve things for our patients. But thank you again, Cameron and Elaine, for having me. Thank you to Ella as well. And thanks, Ros.
Thanks, everybody. Take care.
Thank you.
Good night.
Take care. Bye-bye.